Good evening, all. I must thank Dr. Puri and the Cardiomersion organizers for giving me this opportunity to be here amongst you to present my topic for today's early post-operative management of heart transplant patients. Why the slide is not moving? Okay. As we know that heart transplant patients we feel they are different from other cardiothoracic surgical patients. Do you feel so? Do they need special care? These are the problems we come across. The patient will be in difficult situation. So major complications or problems which may be faced in an early post-operative period are pulmonary hypertension and RV dysfunction, renal failure, primary graft dysfunction, rejection, infections. Other complications more or less similar to the other cardiothoracic surgical operated patients in the early period. And of course the processes newly implemented are immunosuppression management, which are introduced newly to these patients to prevent rejection, and of course the different antimicrobial prophylaxis to prevent infections in the post-operative period. These are the outlines. On these headings I will be talking on my subject. Now coming to the pulmonary hypertension and RV dysfunction. Pulmonary hypertension in many of the end-stage heart failure patients who are listed and undergoing cardiac transplantation, this can happen. If pulmonary hypertension is a documented one in these patients, then they may get worsened following cardiopulmonary bypass and they may induce RV dysfunction. Diastolic RV dysfunction is more or less present in many patients because of ischemic reperfusion injury, and systolic dysfunction can happen if the patient had a pre-existing pulmonary hypertension. How do you manage these patients? You have to optimize the preload all the time in the immediate period, post-op period, and side by side you have to see to it that the contractility is maintained while reducing the pulmonary vascular resistance. For that you have plethora of drugs available in the form of ionodilators, starting from dobutamine to milrinone. You can use epinephrine. Some studies have evaluated and tried levosimendan, though we have not used, not recommended, not clinically very useful as far as end results are concerned. At the same time, you can use selective pulmonary vasodilators like inhaled nitric oxide, prostaglandins, and phosphodiesterase 5 inhibitors to control the pulmonary hypertension. Now coming to renal function and fluid management, this is one of the very important aspects in the immediate perioperative period, post-operative period, because why we are worried is we have to balance our kidney function with newly implemented nephrotoxic immunosuppression drugs as well as the cardiac output in newly implanted allograft heart. How does it function? If it is functioning appropriately, the cardiac output normal, then the kidney GFR will be maintained. Otherwise, in the pre-operatively, we know that these are chronically heart failure patients. Already their kidney perfusion was suboptimal, and immediately they can face problem with kidney impairment. For this reason, you have to be very careful from the beginning. You have to maintain the preload very diligently. The killing pressure has to be maintained slightly higher side, even I would say all the time 7 to 12 millimeter of mercury of CBP, and you need loop diuretics in the very fast post-operative day to unload the excess volume. You have to maintain the preload. At the same time, they are chronically on diuretics before. You have to give diuretics. Loop diuretics, if they are not sufficient, you have to add on thiazide diuretics. And if your patient in immediate post-operative period has developed signs of anuria, oliguria, or the creatinine jumps, then you have to subject the patient early for hemodialysis for the kidneys to open up. And some patients, what happens is the tricuspid regurgitation because of the prior setting of pulmonary hypertension. If the RV dysfunction happens and TR develops, if the CVP continuously RA pressure goes beyond 20 in spite of pharmacological interventions, then you may evaluate by echocardiography with the cardiologist to see what happens to the tricuspid valve. As per the International Society of Heart-Lung Association, you have to address this tricuspid valve by Vega repair maybe. And at the setting of the kidney impairment, if you feel the creatinine is rising, urine is fumbling, then you may go slow in the implementation of the immunosuppression therapy because calcineurin inhibitors are nephrotoxic. Next problem we may face is the graft. As I told you how the allograft behaves. So this is early graft dysfunction, can be primary graft dysfunction, can be secondary graft dysfunction. Primary graft dysfunction, as the name suggests, it doesn't have a particular cause. Cause is unknown, whereas secondary graft dysfunction has discernible causes like hyperacute rejection, pulmonary hypertension, or other surgical complications. The pathogenesis of primary graft dysfunction is torn myocardium secondary to ischemia reperfusion injury during the procedure, which is a major event which can give rise to PGD. PGD can be classified as LV, PGD LV, PGD RV, or PGD biventricular dysfunction, which can lead to heart failure and in severe cases can go on to cardiogenic shock. PGD prevalence is around 14% in the literature, but there are many studies which vary, the incidence varies from 2.3 up to almost 30%, which is a leading cause. If PGD happens and becomes severe, it can cause death within past 30 days. For that, you need to back up with the mechanical circulatory support devices. You have to have a ECMO available in your setup in case PGD becomes severe and non-treatable by maximal pharmacological therapy. These are the risk factors for PGD. They can be from donor side, they can be from recipient side, they can be from procedural side. Procedural factors like ischemic time is very important. If it exceeds more than 240 minutes, donor-recipient mismatch problem happens. Then if concomitant long retrieval takes place, they are the risk factors. Donor age as well as recipient age. If they are high, they are risk factors. Donor ventricular function, if they are not good and they are on high inotropic support, also is a risk factor for primary graft dysfunction. Similarly, if the recipient is very sick on ventilator support, on mechanical circulatory support, and if he had a prior pulmonary hypertension, also is high risk for primary graft dysfunction. These are the criteria for diagnosing the PGD, also the grading and the definition as well. And echocardiographically you will find that LV ejection fraction has come down to less than 40%. These are categorized or classified as graded as mild or moderate or severe dysfunctions, and they are treated accordingly. How you manage the PGD? First thing is you have to support the hemodynamics, pharmacological therapy, inotropes and vasopressors to maintain the organ perfusion while allowing time for this new allograft to recover. In mild cases, low dose inotropic support may be sufficient for the heart to recover back. Moderate cases, you need inotropic support along with IABP. In severe cases, definitely you will require a mechanical circulatory support in the form of ECMO. Now coming to the rejection. Rejections can be cellular rejection or antibody mediated rejection. So acute cellular rejection will manifest, all these rejections will manifest as features of heart failure. Patient will be fluid overloaded. If the patient already extubated in the early posterior period, they may present as breathlessness, they may have desaturation, they may have hypotension, they may consistently, gradually require higher and higher inotropic support, and they will retain fluid, urine output will decrease, capillary perfusion will decrease. So, how you diagnose? You do a echo, you find new ventricular dysfunction is happening, there is valvular regurgitation is happening. Then you sort for cardiac biomarkers, you will find troponin is shooting off, NT-proBNP is shooting off. Then you do a biopsy, if possible as early. It is very difficult at that time to do a endomyocardial biopsy because shifting this patient to cath lab is very dangerous and he is unstable patient. So, on the basis of clinical as well as echo findings and biomarkers, you have to start treating the patient with pulse steroid therapy, which is we use usually high dose of methylprednisolone at the rate dose of 20 mg per kilo intravenously per day in 2 divided doses. Then after 3 days we come back to 1 mg per kilo per day. If there is no clinical response within first 24 hours of completion of this high dose pulse steroid therapy, then you go for polyclonal antibody, that is rabbit antibody, at a dose of 1.5 mg per kg per day for 7 to 10 days. In the meantime, you have to support the heart and the patient with inotropes, vasopressors and mechanical circulatory support to maintain the adequate cardiac output till the recovery of allograft happens. These are the gradings of acute cellular rejection as per the ISHLT grading 2004. Grade 0 there is no rejection, 1 are mild rejection, 2 are moderate rejection, 3 are severe rejection. Ideally 0 are and 1 are many times we don't treat depending on the echocardiographic findings. Antibody mediated rejection is less common but very dangerous, and it happens in response to mismatched human leukocyte antigens, that those are existing on the donor specific, in the donor endothelium, graft endothelium. These are called donor specific antigens and they will immediately respond. So AMR results in graft ischemia, thrombosis and cell death in minutes to hours. Ventricular dysfunction without significant ACR, suppose you by chance got a chance to do a biopsy, you will find if there is no features of ACR, it is an indirect indication that it's an antibody mediated rejection is happening. As far as treatment is concerned, again, pulse steroid is the principal therapy. Immediately we start. Then other things like intravenous immunoglobulin, plasmapheresis will be given. After that, if it doesn't improve, then we give rituximab or other cytolytic therapies like I told, anti-thymocytic globulin. The protocol for rejection is, as I told, methylprednisolone, plasmapheresis, and then you have to give rituximab if don't respond. Details of the protocol everywhere it is available. You have to make this available as a protocol in your setup. If you are doing the transplants regularly, if you have to make sure that the drugs are available nearby, even if not in the center. Then immunopathological findings of acute MR grading, again 0, 1, 2, 3. You can check, you have to do the histologic and immunopathologic tests by the pathologist. Grade 0 there is no histologic, no immunologic findings. Grade 1 only histologic findings. Grade 2 both, and grade 3 severe histologic and immunologic findings. Now, hyperactive rejection is nothing other than antibody-mediated rejection, and if donor-specific antibodies are there through the donor-specific antigens, it can happen within minutes and hours. The patient won't be able to come off bypass and can result in sudden death. So, you have to be very particular to see pre-operatively what is the panel reactive antibody score, and accordingly, if your score is high, some places, some institutes, they can do prospective matching, which usually is not possible. So you have to be careful for this hyperacute rejection. Again, treatment is in the line of antibody mediated rejection and maintenance. Then coming to the maintenance, immunosuppressant therapy. This is the mainstay of the transplant program. You have to be very diligent, you have to make a protocol available, and we do start from the pre-operative period, calcineurin inhibitors and mycophenolate mofetil. Tacrolimus and mycophenolate mofetil we give pre-operatively, start in the day of the surgery, transplantation. Then intraoperatively we start with methylprednisolone at the time of release of the cross clamp after the transplantation. Then post-operative we give 2 more doses, followed by decreasing the dose to 1 mg per kilo per day in 2 divided doses. Then we switch it over to the oral prednisolone once the tacrolimus level is achieved. And always you have to balance it with the kidney function. You keep watching the kidney function, gradually escalate the dose, because you need to upscale the immunosuppressant therapy to maximal tolerable limit with renal function in the normal limits in the immediate post-operative period for some time. Then some induction agents, some people they use, those are like polyclonal anti-thymocyte antibody, as I told, rapid ATG we use, equine ATG we don't use because of reactions, and other agent is IL-2 receptor antagonist basiliximab. Mostly people use basiliximab who are used to use it. But there are special indications, like if the recipient has a calculated PRA of more than 10%, marginal donors, and pre-operative renal impairment is there, serum creatinine more than 2 mg per deciliter. If any center has already using this as a regularly, they are used to it, they may use it. Some people earlier they were using more, but if the recipient has got a class 1, class 2, 0% PRA, regular antibacterial prophylaxis just before surgery and through the surgery. And as per the International Society of Heart Lung Transplantation, they usually stop the antibiotics within 72 hours, but in our setup, in the Indian setup, we see to it that the invasive devices like chest drains and invasive lines are out, patient is mobile, then we stop the antibiotics. That is around 5th day of the post-operative period. And after that, along with the immunosuppressants, maintenance immunosuppressant, we have to give antiviral prophylaxis against cytomegalovirus. We have to give antifungal prophylaxis against aspergillus. Those we continue for 3 months, and then other prophylaxis against pneumocystitis, girovacin, pneumonia, toxoplasma gondii, nocardia. These are usually one drug is sufficient, that is trimethoprim sulfamethoxazole. We give up to 12 months, and this is recommended. And now coming to other complications, I think these complications are, as I told, more or less same as the other cardiothoracic surgical patients. So I am not repeating. Like, only difference in these patients as far as bleeding is concerned is that all end stage, most of the end stage heart failure patients pre-operatively they will go on anticoagulants. That's why they may bleed more. And prior surgery requiring, already some patients they might have a host of patients like valvular cardiomyopathy already has undergone valve replacements, ischemic cardiomyopathy already has undergone CMEG. These are the some cyanotic congenital heart disease patients like Fontan operated patients. These patients they have extensive dissection and adhesions and suture lines. So they may bleed more, and these are heart failure patients, they are nutritionally poor, so they may bleed more. So the rest of the treatment, you know how to do it. Surgical bleeding, you have to explore it, and medical bleeding, you have to evaluate with the coagulation profile platelets, thrombus elastography, then you can replace the blood and blood products, whatever deficient products. Now pericardial effusion, as per the guidelines, usually in dilated cardiomyopathy, cavity is big. Some amount of collection will be there. You don't need to bother much, but only thing is that you have to screen daily as per the routine protocol recommended by ISSLT. You have to do a daily echo as far as long as patient is in the ICU, you see how much collection is there. If it is not significant, you don't need to bother. If it is causing hemodynamic compromise, yes, you have to drain it. otherwise no. And vasopressia, you know the treatment, and this happens in some of the patients very severely. Then you need to treat it very aggressively, and fast life management we do norepinephrine followed by vasopressin. And nowadays in 2021 guidelines, ISSLD guidelines, they say single dose methylene blue they should use, but we have not used. Denervated heart, we know autonomic nervous system is cut off, so there will be variability. So resting heart rate will be around 90 to 110. Very rarely you will get a bradyarrhythmia. Usually the rate is maintained. If bradyarrhythmia happens, then you can pace the patient with temporary pacemakers already placed epicardially. Otherwise, this heart rate will be intrinsic heart rate only. There will be no trouble. Arrhythmias, yes, can happen if there is a tachyarrhythmia in the form of atrial fibrillation. Many times happens. Ventricular arrhythmias can happen. These arrhythmias, if happens repeatedly, they are a subtle indication that rejection or coronary cardiac allograft vasculopathy is happening. Mainly rejection. In immediate post-operative tachyarrhythmia is a subtle indication that rejection or graft dysfunction is happening. Hypertension sometimes can happen if the patient, particularly ischemic cardiomyopathy patient, if they are hypertensive before, and if in children you get a bigger heart, adult heart, that is, we call it big heart syndrome. And also when you implement calcineurin inhibitor, it has a hypertension as a side effect. All these things together, we have come across one of our patients had a Bress syndrome. That posterior fossa bleeding can happen because of severely uncontrolled hypertension. You can control with vasodilator initially, they can then calcium antagonist. Now, summarize my talk. In the immediate post-operative period, early care has to be given very diligently. You should monitor the patient very appropriately. You should do echocardiogram daily. In case you are not monitoring with pulmonary artery catheter. In our center we do not use pulmonary artery catheter, but we do use echo to monitor the functions. We see the pericardial effusion. If the patient had a documented pulmonary hypertension, we keep a very close track on pulmonary pressures. We maintain optimal preload in the immediate post-operative period so that the intravascular volume holds and the kidney function goes on so that you can gradually escalate the immunosuppressants. Bleeding needs to be controlled. Close monitoring of the kidney function needs to be done. Diuretics, of course, will be needed from fast post-operative day to unload the third space volume. We have to treat the pulmonary artery hypertension effectively to prevent RV dysfunction. Infection prevention and treatment always takes a foreground. Implement immunosuppressant therapy and maximize balancing with renal function and total leukocyte count. Back up with mechanical circulatory support devices like ECMO if you are a heart transplant center. Thank you very much.